Hey, this is Dr. James Hall. We're going to talk about NSAIDs and kidney disease, non-steroidal anti-inflammatory agents or drugs, and how they affect the kidneys. I am a nephrologist. I've been practicing for about 20 years, and I'm just going to talk about how NSAIDs affect the kidneys. We get a lot of patients in our clinic on non-steroidal anti-inflammatory drugs, and they get referred here to our nephrology clinic for acute kidney injury, chronic kidney disease, hyperkalemia. And the first thing I do, you already know the answer to this, is stop the ibuprofen, the Mobic, the Aleve, the naproxen. These drugs predictably drop your GFR. Typically what they do, NSAIDs inhibit cyclooxygenase, the COX enzymes, which produce prostaglandin. Prostaglandins are vasodilators. So if you decrease your production of prostaglandins, you can basically cause vasoconstriction. So NSAID-induced prostaglandin inhibition leads to vasoconstriction, and that causes decreased renal blood flow, and that causes decreased GFR. So putting patients on these drugs can cause afferent arteriolar vasoconstriction in your nephrons, and that decreases your blood flow. That's why we see a rise in creatinine when you put patients on these drugs. What are the side effects? Hyperkalemia. Sometimes it can worsen your blood pressure. Sometimes it can cause hyponatremia and also swelling in the legs. That's why we always look at medications when we get CKD patients, because medications could be the reason that they're having the swelling, the kidney disease, or the electrolyte abnormality. So always look at medications. What else about NSAIDs? The other thing about NSAIDs is, how do you know when to stop NSAIDs in a patient? Well, if you put a patient on one of these agents and their creatinine goes up, the GFR goes down, you should probably stop it, because that may be the culprit. That may be the reason why their GFR dropped. Now, a patient with a GFR above 60 can tolerate NSAIDs without any problem. But a patient with a GFR below 30, which is stage 4 kidney disease, usually can't tolerate this class of drugs. So we usually just stop it. Now, how would you know who's at risk for acute kidney injury when you put a patient on NSAIDs? Anybody with CKD is obviously at risk. You already know that. Anybody with hypercalcemia, that's the other high-risk patient category. Anybody who's dehydrated, that's another high-risk population. And any patients who are on an ACE inhibitor or ARB. Those are all high-risk patients that when you put them on an ibuprofen, Aleve, or Motrin, you should really look to see if this patient may have a reaction to that drug. And then patients could be actually allergic to NSAIDs. They could have a allergic interstitial nephritis, which is kind of like an allergic reaction that your kidneys have to drugs. Incidentally, any drug can do that. So when you put patients on medications, you're starting a scientific trial with a patient of one. Keep that in mind, because in nephrology we get to see all the bad things that happen to kidneys with drugs. So we're very less likely to start patients on certain drugs because we've seen all those major reactions and major complications from medications. So alternative pain medications, what are some of the things you can use in your patients instead of NSAIDs when they come in and say, oh, my shoulder hurt, my hip, my back, my neck and my back? Well, what I normally do, I look for muscle relaxants. Those are really good, tolerated by the kidney without problems. I look for opioids. I try to use those as a last resort, but opioids are great pain medications. Skin creams, like some of your pain creams, like your capsaicin or your aspirin cream, and those type agents. And there's a lot of newer agents that the compound pharmacists will compound for you that contain gabapentin, NSAIDs, and a muscle relaxer. So look into that also for your patients. Cannabis-related pain medications and creams. I've recommended that to patients. Um, so a lot of patients like the CBD pills or the CBD cream. That seems to help. NSAID cream, we talked about that. And also colchicine. Colchicine is an anti-inflammatory agent that's approved for the use in gout, but some patients respond really well to colchicine when they have arthritis, when they have some type of joint inflammation, and you can't use the nonsteroidal anti-inflammatory agents. You can use the colchicine. And finally, steroidal anti-inflammatory agents, such as corticosteroids, prednisone, solumedrol, cortisone. Those medicines are really good for patients who cannot tolerate NSAIDs. You can use a Medrol dose pack, you can use prednisone taper, or you can use intra-articular injections to try to help your patients relieve their pain. So, just recap on NSAIDs and kidney disease. NSAIDs, block those afferent arterioles and cause vasoconstriction through basically inhibiting prostaglandin, and that will decrease your renal blood flow and your GFR. Patients with a GFR above 60 can tolerate NSAIDs without any major problems. Patients with a GFR less than 30, usually I try to avoid NSAIDs in that population. Some alternatives could be your creams and that type thing, as we mentioned earlier. But keep this in mind. This is just a little video we wanted to do, but we have more videos like this on our page. Nephrology referral patterns, tips to help you manage patients better in clinic. We have a free webinar you can click below also. And I hope I see you again in the next video. Check out our course if you want to dive deeper into how to manage nephrology patients, CKD patients in your primary care setting. Basically, we've created kind of a mini fellowship for you. So check us out. I'll see you in the next video. Thank you.